to treatment now and guidelines. So as we know, venous thromboembolism is still a leading cause of death and disability amongst patients having surgery, and as Andrew's pointed out, also patients admitted to hospital for medical reasons. And the prevention and treatment of VTE is probably one of the most comprehensively investigated areas of medical and surgical practice. And as you've heard from Andrew, there's good level 1 evidence. It has to be said mainly from commercial studies, industry-sponsored studies, to guide us in many of the situations that we find ourselves in day-to-day practice. But when you start looking at the field, it becomes immediately apparent there are still a lot of gaps in our knowledge. And perhaps as a result of that, or because of that, many different guidelines have been published related to VTE over recent years. And if you look on the Google and you look at these things, this is by no means all of them. There are many, many guidelines coming from many different bodies, from many different countries, under the auspices of many different organisations, trying to guide us in the treatment of VTE in a broader sense. The guidelines that are probably best known to all of us are the ACCP guidelines, originally in the 7th edition in published in 2004, and then the 8th edition in 2008. And as anyone who's tried to read these, they are awesome documents, extraordinarily thorough, running to many hundreds of pages. In the UK, we have a body called the National Institute of Health and Clinical Excellence, and one of the roles of NICE, as we call it, is to develop clinical guidelines, and NICE has produced a number of these related to VTE over recent years. This is the most recent one, published 2 years ago, on DVT prevention. And in the UK, this NICE guideline is really the gospel. This is what we stick to. But of course, the UK is a complicated place, and becoming more complicated because Scotland, although officially still part of the UK, has many of its political functions devolved. And in Scotland, there's a completely separate group called the Scottish Intercollegiate Guideline Network that also produced guidelines on many different things, including VTE. And one of the difficulties for us is that NICE and SIGN don't always agree on everything. But hey-ho, that's the way it is. The American Heart Association, as you probably know, have also published guidelines very recently last year, looking at a number of VTE-related topics, in particular the ephemeral DVT. And in general, they've been fairly enthusiastic for recommending more than what you might call basic care. So things like catheter-directed thrombolysis, systemic thrombolysis, etc. And the most recent kid on the block is the 9th iteration of the ACCP guidelines, which were published earlier this year in CHEST, and these are available obviously on the internet as well. Now, the ACCP guidelines seem to be quite different from many of the other guidelines that have come beforehand, and in particular the previous ACCP guidelines. And having spoken to colleagues from the States, people like Tony Comarota, not all of them are entirely happy with the way that the rules of the game changed. But you know, there'll be a range of views on whether that was correct or not. So each chapter was basically run by non-conflicted and non-expert methodologists. So these were experts in methodology, but not necessarily knew anything about VTE. And the idea of these methodologists was to make sure that the naughty surgeons and doctors didn't bring any bias into the various chapters. The reviewing of the literature was more robust than previously, using the grade approach, which is also something that NICE use in the UK. And there was a general switch towards increasing the importance of clinical outcomes rather than surrogate endpoints. And of course, we've seen this in arterial work as well. Rather than looking at restenosis, we're more interested in whether the leg is still on or not. And of course, there's always been financial conflict of interest, but on this occasion, they brought in what they call intellectual conflict of interest, which seems to me, if you've ever done any research in the area or published a paper on the subject, you're not eligible to vote, which again seems to have annoyed quite a lot of people. And the consequence of this is that we seem to have less guidelines now than we did almost 10 years ago. So if you look at the 2004 ACCP guidelines, there are 123 level 1A guidelines coming out of 540 pages, 2008 182 level 1A guidelines out of 900 pages, and now I'm afraid we score a rather disappointing 29 level 1A guidelines coming out of a further 801 pages. And it's quite difficult to know whether we're going forwards or backwards. Whether this reduction in recommendations is the result of excellent new research, it doesn't seem to be, or whether it's that before we were misinterpreting the available evidence is not entirely clear. Anyway, if you look through the guidelines, and there are 800 pages, and reading it takes a couple of months, really. You know, there's not a lot in here that's particularly new. You know, the standard treatment of acute proximal limb DVT is the usual thing, treatment with low molecular weight heparin or fondaparinux, starting vitamin K antagonist at the same time, talking about getting on with treating people even if you haven't got tests back, proving DVT in high-risk cases and so forth. One of the interesting things, and again this has caused some difficulty, is that in fact they're very lukewarm now about thrombolysis and intervention for DVT. I mean, it says here that they suggest anticoagulant therapy alone over catheter-directed thrombolysis, over systemic thrombolysis, and over interventions, or surgical interventions, which seems in stark contrast really to the recommendation from the American Heart Institute Association, which came out a year ago. Is it still true? Yeah. Okay. They seem very concerned about the overdiagnosis of what they call harmless distal, like calf DVT, using whole leg ultrasound, because they believe it results in unnecessary anticoagulation and avoidable bleeding. So that's likely to change practice quite a bit. So they recommend only treating people if they're high risk for extension or have severe symptoms. We're a bit short of time. They say that patients can be treated at home, which has been standard practice in the UK for as long as I can remember, although they point out the evidence for this is fairly weak. They point out that people with DVT don't have to lie in bed while they're being treated. Again, we thought we knew that, and that's been standard practice in the UK for as long as I can remember. But again, they point out that the evidence base for that is very weak. They talk quite a lot about upper limb DVT, and that's not necessarily the subject of today, but again, they point out repeatedly that the quality of evidence is at best moderate, and they're very lukewarm about thrombolysis and first rib removal and stenting and such like, which you hear talked about at many of the big venous meetings. So it does give people a lot of wiggle room, but in general, the heat seems to have gone out of the enthusiasm for what you might call adjuvant treatments for proximal iliofemoral DVT and upper limb DVT. If you don't want to read all 801 pages, this is a very useful summary from the ACCP, so it's original source, but it summarises it very nicely. And there are quite a lot of slide sets available on the internet as well, which are excellent. So, what can we conclude from this? Well, there are thousands and thousands of pages of recommendations and suggestions, and even experts, I think, would not be blamed for being rather confused about the current situation. And the thing is, the evidence base is surprisingly weak, where commercial interests are not in clear evidence. And that leaves some pretty big gaps in our knowledge. The problem of, and I'm not sure whether this is largely just a United States problem, but the ACCP comes out of the States, so that's where it's been exposed, if you like, of financial and so-called intellectual conflict of interest is clearly a big issue. And as I say, there'll be a range of views on whether what the ACCP decided to do was appropriate, and I'm not in a position to express an expert opinion on that, really. It's a matter of opinion for other people. And in general, I don't think the ACCP9 really tells us anything we didn't know already. Working in the UK, cost effectiveness is increasingly important, and we've been trying to get money from the government to do a randomised controlled trial of thrombolysis and catheter-directed thrombolysis and proximal iliofemoral DVT. But they basically said, well, even if you were to show that it was clinically better, say at 2 years, in reducing PTS, it's so expensive that it would never become below our willingness to pay threshold, which is currently £20,000 per qualy. So they're not going to fund that, so we're in a bit of an impasse. But what we do need is urgently, we need publicly funded non-commercial RCTs and other studies to try and take us forward. And you could take the view that without further research and a better evidence base, just rehashing the old evidence and coming up with yet more guidelines may not be a particularly